I'm going to tell you a little bit about me, more in depth. I am Dr. Ferguson. I am from the small town of Winnie, Texas, which is down by Beaumont, a little bitty place. It's hard to raise in the country, and I loved it. But I was also glad to get out there. I went to Texas A&M for college, anybody's Aggie. And then I went to the University of Texas for medical school, so I'm a trader. I did both, which is good. And then I went to the University of Alabama, and I trained in internal medicine. And so, I keep going. So at the University of Alabama, and there I did internal medicine for 3 years. So I am internal medicine trained, but I did a fellowship, an extra year in palliative care. Palliative care are patients with diseases you can't cure. Okay? And so a lot of what we do in palliative care is work with patients to help them with chronic disease, to help them do as good as they can as long as they can. When you say palliative care, a lot of people just think hospice. I don't think that's at all what my job is. It is a lot. It is part of what I do, and I love that part of my job, don't get me wrong. But when you say the word hospice, everything is sad, and everything it takes a conversation to a different place. And to me, what my job is to help people live. It's not, when it comes time to they do pass, I want them to be peaceful. But as long as I can help them to live and do as good as they can, as long as they can, that's what my job is. And it's to manage symptoms. Symptoms that can be from restlessness, confusion, anxiety, and pain, to symptoms of anorexia, I'm not eating, I can't move, you know what I mean, those kind of things as well, fatigue. And so symptoms come in a large range, from hyperactive symptoms to hypoactive symptoms, and we'll go through that a little bit. So if asked me to come talk about dementia today, this is really personal to my heart because if you don't know, I took care of my grandmother. I helped with her care in dementia. My grandfather took care of her. He did the majority of the work, and for a man that, before that, she washed his hair in the sink and clipped his toenails every day, to transitioning to him being her caregiver was a huge move. And I was in high school around at that time. She had dementia from the time, the first time I remember I was 7. I remember because we had Thanksgiving dinner, and she made 1 can of green beans, which my grandmother never made canned green beans. And she certainly never just made 1 can, she cooked a huge meal. And so that was the first time that I remember that she had dementia, because my mom came over and said, she only made 1 can of green beans. You know, don't eat the green beans. There's not enough to go around. And so that's when I remember. But I lived my whole life with her having dementia and advancing through that. And then when I came into high school, there was more assistance needed, some with her care. And she didn't actually pass while I was in college. She had Alzheimer's, and she had a very slow, long progression. And so I do have some personal experience from my family side, and then obviously the medical side of my experience as well. When they say talk to you about dementia, I'm going to tell you, I think that many of you are probably caregivers, I'm assuming, and you have probably read as much as you can and know in first-hand experience on this as well. So some of this I know, I'm going to talk, I want to give you some information. However, I'm also very open to questions and whatever you want to gain, if you have specific things about this. But I wanted to explain the difference in, I'm sorry, I need to learn how to use it. Okay, the difference in palliative care and hospice, we'll go through for a second, the stages of dementia, symptoms, treatments, and then I'm going to go through in detail advanced directives. I feel like that is something that as physicians we do a really poor job in explaining to patients and families. A lot of times they're done with an attorney who actually has no medical experience and understanding in a hospital setting, and there's some things that are real important for you to understand about that. So palliative care, patient and family-centered care, optimizes quality of life. Our goal is to anticipate, prevent, and treat any form of suffering. There's physical suffering, which I say is typically, honestly, my easiest job. Treating pain or nausea, vomiting, those are medicines that I know like the back of my hand. The symptoms that come along with psychological, psychosocial suffering and those kind of things, those are the harder things. Those are the things that take more time to deal with. But palliative care goes throughout the continuum of an illness. Physical, intellectual, emotional, social, and spiritual needs. Facilitating patient autonomy, so every patient makes different decisions. when you have a chronic disease. And people need to know what their options are, what their choices are, and those kind of things. And making sure that people have access to that information and they understand their choices in their care. Palliative care is offered with other care. So a lot of times people will, the world of hospice, they will say once you start hospice, you can't do any of your other previous care. That is not true with palliative care. We have an outpatient palliative care clinic where we see patients for symptom management, and in that clinic, they still go see their cardiologist, their neurologist, their pulmonologist. Unfortunately, incurable conditions happen with most every spectrum of the disease. And patients with incurable conditions, but it's not prognosis dependent. So unlike hospice, which typically they'll say you must have a prognosis of less than 6 months if your disease follows a natural trajectory, palliative care starts much further upstream. So here's palliative care, a little scope of it's hospice, but we should manage a lot more patients than that. So dementia. Dementia itself is not a disease, it's a category, right? It's a group of symptoms involving declining cognitive function and behavioral abilities. It affects one's daily life and accompanies a disease, such as Alzheimer's disease. So people often get confused about this. They have dementia. Well, they do have dementia, but that in itself is not the diagnosis. That is just a category. They have Alzheimer's dementia or vascular dementia or Lewy body dementia. And the truth is, I believe very strongly that there's a lot that we do not know about dementia, right? And so when it comes to treatments and therapies, some people do have some benefit with some of these medications. Some people, medications and treatments and therapies, some people do not. Some people do have benefit with dietary modifications. I don't know if any of you have tried, but if you've read very much, they'll talk to you about low protein, all natural, all those things. I've had some patients that have had some benefit with that for a period of time at least. But I think the reason that different people have different responses is, number one, we're all different. That's true with any medication. But also, I believe there are multiple categories of dementia that we don't yet know exactly where people fall. And I don't know if some of you feel that way kind of about your loved one. The brain cells and neural pathways are damaged or destroyed. And so that's true with all forms of dementia. And it's progressive. So the symptoms keep changing. It's also chronic. It's also terminal, eventually. So the stages of dementia, the standard scales are typically, there's the Alzheimer's Association stages, it's 3 functional stage model, early, middle, and late. What we use in medicine more typically is the global deterioration scale. It's the 7-stage scale, and hospice is stage 7. So when you're talking early, middle, and late, early stages are forgetfulness, losing track of time, being lost in familiar places. I'll say my dad probably has started in that stage right now. He's around 75, and we have a little bit of that. The middle stage, symptoms become more clearer. Forgetfulness of recent events and people's names, becoming lost at home, increasing difficulty with communication, needing help with personal care, experiencing behavior changes. And then the late stages, unaware of time and place, difficulty recognizing relatives, having increased need for self-care, difficulty walking, behavior changes that may escalate into aggression. As you know, some of when you hit these stages is fuzzy, right? As to whether you're really middle stage. It's not all clear cut. The world of medicine is not that way, and certainly a person is not that way. And also, I feel like so often in our heads we think, oh, well, this stage may be long, and this stage a little shorter, and this stage shorter. As you probably know, if you've dealt with dementia for very long, my grandmother was in this stage for almost a decade. It was a very long last stage. And so it just depends on your disease, and to some degree it depends on how he is and how we handle things as well. So this in the world of medicine is what we use, the FAST-7 scale. I don't know if you've ever seen this, but what it looks at, this is expected untreated duration in months. I do not pay attention to this column. The mental age, I do pay attention to, because I think that this part is very important. Because when you're trying to reason with your loved one that has dementia, trying to remind yourself that you're trying to reason with someone that's a 5 to 7 year old, it is helpful. Because I can tell you that when my husband does something versus I have a 5 and a 7 year old, versus when they do something, I can get much more angry with him because my expectations are much different than they are with my child. And so I do like this scale in that it sometimes will for. And when you're frustrated or when they're angry and they're screaming at you or calling you names and all those things and you're trying to rationalize that out, it helps a lot when you think, I'm dealing with a 5-year-old here that has a larger vocabulary. And so I can calm down and go, okay, think about this rationally, let's move forward. And this is a mental status exam. If you're in the early stages, you're probably still getting tested this, or your loved one is, when they go to the doctor. And so it is important, it is helpful. For the world of hospice, this is helpful to know because people don't want hospice, sometimes they need hospice, they need help. Because caring for your loved one that has dementia is no easy job, it is not for the weak. It's a lot of work. And good work, you love it. I wouldn't change any of the time that we've had with my family in that situation. It doesn't mean you're not exhausted. It doesn't mean that you shouldn't take advantage of the help that is available to you and offered to you. And so, typically for a patient to qualify for hospice assistance with dementia, they're going to need to be a 7A on this FAST-7 scale. And so that's typically when nurses and aides can come in and help. And, you know, to me, I say all the time, people choose the role of hospice. Number one, if their symptoms are severe, for pain. Number two, there are people that just are tired and have lived to 102 and they're just ready. But the third one is to try to keep their loved ones at home as long as they can, right? Because you need that help to take care of them and keep them in the home. Because most of us, that's at least when I was caring for my grandmother, our goal was to try to take care of her at home as long as we could because we did not want to have to put them somewhere. And now let me say this too, no judgment if you do. Because what you also have to do is reflect honestly with yourself. You want the best care for your loved one that you can do. And if you can't do that on your own, and if you can't afford help to do that, which is incredibly expensive, then there should be absolutely no shame in trying to place them in somewhere hopefully near your home where you can be in and out of there regularly, so you're still very involved in their care and loving them, but making sure there's 24/7 care available for them as well. And it's hard to do 24/7, right? When it's just you. It feels almost impossible sometimes. And so we had family nearby. My grandparents lived about 10 miles from us, but we may not, and then that puts a whole lot on the caregiver. So this chart is helpful in that way, kind of understanding where we are along the disease, and that's, we use it a lot as the physicians in medicine. I want to talk a little bit about imperatibilities and the things that happen in the brain, because then we start to talk about what we do. And you probably know a lot of this, but so gross motor skills. With any form of dementia, there comes that time that there is some loss in gross motor function, balance, coordination, movement, and gait. I know my grandmother, she had Alzheimer's, and so her memory loss came before her functional loss. Sometimes with Lewy body, you get the opposite. Their functional loss, and you still feel like they understand more longer anyway. Just depends on your form of dementia. But she didn't lose gross motor till later, and then she started looking more Parkinson's-like, a shuffling gait with her walker and those things, and then to the wheelchair and that. But also trying to maintain gross motor skills as long as you can when you're the caregiver is incredibly important, right? Because if a person becomes bedbound, that changes your care completely as well. And so trying to maintain that. Fine motor, also incredibly important. It is helpful, at least if they can keep this dexterity and try to feed themselves. So transitioning from that place where they can use utensils to going to finger foods, that's all part of, you've been a caregiver of moving through that trajectory as well, and things to keep in mind. And then swallowing is a very large part of advanced dementia. I don't know that most people know how people with dementia die, right? Because is it actually dementia, right? But for most patients with dementia, the end of life often comes, it is attributed to the dementia, but it is swallowing, so aspiration, dysphagia, so they start to get recurring pneumonias. And we'll talk about feeding tubes in a little bit, but even with that, there's the risk of aspiration, and so pneumonia. In the old days though, let me say, they used to call pneumonia man's best friend. It's considered a very fast and peaceful way to go if people are managed properly. Infection can be UTIs, because with incontinence, bedbound, in a brief they're not sometimes fully emptying their bladder. You end up having either they don't empty their bladder and they end up with infections, or then you move on to a Foley catheter, which is in place, which then also increases risk of infections, right? So you kind of are stuck between a rock and a hard place. So pneumonias, urinary tract infections are two primary ways that we often lose patients at the end of life with dementia. And it's important if you're a caregiver to understand that process, because if they start to have hospitalization or recurring pneumonias or urinary tract infections, that's an important place in your disease trajectory. Because if those infections become back to back, the rate of decline speeds up often from the rate of decline you have previously had. Does that make sense? People typically keep the same rate of decline. Some people have very rapidly advancing dementia. 2 years ago was different than 1 year ago, is different than 6 months ago, is different than 3 months ago, and it changes very quickly. My grandmother's was the complete opposite, like I said. It was a very, very long, slow road, and she stayed that way until the very end of life. And so people often stay the same, unless there's some large acute event, like if you had a stroke on top of it, right? I mean, that would change things, but that's separate from just your regular natural divine dementia. But swallowing and chewing and all of those things are important for your motor skills. Reasoning and judgment, understanding cause and effect. They start to lose the ability to do that. Problem solving, decision making, impulse control is huge, and then their social filters. People don't think a lot about the frontal lobe. The frontal lobe of your brain is what, when you get angry or frustrated, what you go, and you don't scream it all out, right? Or when you have pain, if something really hurts and you're moving, and you go, oh, that hurt, okay, stop that. I know it's about to stop. They're repositioning me. When you have dementia, though, you lose those filters, right? You don't understand that that pain's about to stop. So if there's a pain and you're moving them, it's, right? Because they don't know it's about to stop, and they don't sometimes have that filter. Or if they're angry at you. What you used to been like when I rolled my eyes at my husband, now it becomes a verbal response, and can be much more than what you would have ever expected. And the truth is, that's not them. They don't mean that, right? But their impulse control and their social filters are effective. Abstract thinking. So obviously, these are some of the first things that we think about, like high level of thinking. That's concepts of time and money, understanding sarcasm, figures of speech, which my family is fairly bad about this category, and we have to watch it. And then attention, ability to focus, task completion, and multitasking. And so this was a big thing with my grandmother because she was a doer, an active doer. She ironed the sheets on the bed, right? I mean, like this was a whole, yeah. And so whenever she started to get sick, we had to come up with activities essentially almost all day because she had always spent her whole day cleaning, ironing, vacuuming, changing the bed. I mean, she never sat still. And so that was her personality. That stayed her personality. It's who she was. And so our days were spent accommodating to what her losses were that were most significant and trying to adapt her schedule, but trying to also keep almost a day full and a day planned. I say a lot to my family now with my kids. I feel like sometimes it's like her because my whole job was to make them happy, to keep them active, and exhaust them by the end of the day, right? That's my job currently, I feel like. We want to have good days, happy days. We want them by the end of the day to be exhausted, though, and I felt like that was my role with her as well. Is that I was trying to keep her active, trying to keep her happy, trying to move through the day, but at the end of the day, I wanted to have done enough that she slept well too, right? Because it made my job, our job as caregivers easier, okay? So, the memory center, the hippocampus. Of course, the brain is really complex. We're going to kind of simplify it a little bit for this talk. It's found to be one of the hardest areas of the brain by dementia. You have difficulty forming new memories, right? And so old memories can often be present for a much longer period of time, but new memories, short-term memory is harder. Long-time memories are the last to go. Factual memories fade. Sometimes emotional memories, what we see, are more resistant to deterioration. So those things that are associated with a song, with their emotion, full of love, weddings, these things that have emotional impact with them along with different things that cause emotion are typically things that we hold on to longer. And that's important as we're talking about, depending on your loved one and what their symptoms are. When we make activities That's important too, because emotionally what stimulates them, right? Is it music? Is it sound? Is it being outdoors? What is it that we can try to do to adapt to them in their care that would help them to hold on, or maybe recur memories, or keep them calm, because it's a beautiful, calming, loving memory that comes back with these triggers. Concepts of time and space and directionality are certainly impacted. The emotional center, the amygdala. Emotions still remain intact, we all know that, right? Because when happy, I can't tell you the number of times my grandmother said to me a day, I love you. I love you. That was her. I love you. I love you. I love you. I love you. That was great. And I know, so emotions are still certainly there, but also so can be anger. So the emotions can be incredibly intense in a negative direction at times as well. And you've been a caregiver for very long, and you have experienced that, and if you haven't for very long, you should prepare your heart for that, because it hurts too. They respond and react to the emotions of others. Obviously, in the more advanced states, you could see less of that. Although, in caring for someone with dementia, and in the number of patients I take care of with dementia, I will tell you, I probably believe that there is more inside of that brain and inside of them than most people that are walking by that just interact with them. I feel like we don't give them near enough credit for what they process. They process much more slowly than we do. But do I believe that they understand? Yes. Do I believe that they forget very quickly? Yes. But do I believe that there is their ability to understand our emotions and that we love them? I think that's also, this is part of, when I say to a lot of caregivers, when they're in the hospital with their loved ones, and I say, do they know you? And they're like, well, they don't know my name, but they know you. They know you because they know who you are. They know the emotions that you bring, and you are there. Does that make sense? Y'all know probably what I'm saying, but I just want to make sure I'm being clear about that. They may not remember your words, but the emotions linger. Like I said, the comfort that you bring, the peace that you bring, all of those things are incredibly important. Survival responses remain intact, and you've probably seen these because they will fight. The hospital, we see a lot of this because when they're in a new environment and they know none of us, that fighting anytime that we get too near, because we're real bad about not stopping to say, okay, I'm going to listen to your heart. Because if anybody started pulling my shirt down, I can tell you I would have a response, right? But we expect them not to. We expect to be able to walk over there and just start listening to their chest without saying anything to them, and they're not going to start all of this. And nobody would do that, right? You, though, who are without dementia, I'm sorry, I'm on call, so, but without dementia, you understand what I'm doing, right? You know you're at the doctor's office, and she's probably going to listen to my chest. You're not going to fight with me. But when they don't understand, that's a whole other ballgame. So being sure that we're being clear and that we're going slow and that we're trying to explain everything that we're doing is huge in the regards to the fight. Flight, I want to go home, I got to get out of here. That can even happen when you're at home, and I'm sure a lot of you have experienced that before too. And trying to help them to redirect, right? Can we just go, look, I would start music, I would grab snacks that I knew she loved, to be like, oh look, there's some cookies over here, let's go do that for a few minutes. Can we go have some cookies? Well, I want to go home. We'll go home after that. Let's just sit down here. So that redirection to try to keep them from trying to leave, and I do that in the hospital as well. Unfortunately, in the hospital, we also have restraints and all these really ugly things, right? Without enough time that we spend. So, and then fright, obviously the scare of not understanding what's happening is huge. And then unable to control their emotions at times. And sometimes we get to that place too, I think, as caregivers, where we can't control them either. And the hard part is I've been working with caregivers for so long, the guilt that comes with that is so hard, because once you've screamed or once you've lost your cool, you just feel awful. That the one thing I try to keep reminding people is remember that, thank goodness they don't remember. You know, their short-term memory is they're not holding it against you, you're holding it against you. So keep moving forward, and of course, you try to reevaluate how you can try not to do it next time. Like I said, trying to remember that chart, what you're dealing with, a 4-year-old, you know, because your response may be different. Because exhaustion does that to you, right? To all of us. It's important to think of these things, and I say them, visual changes in perception, because sometimes I think there are things that are changing with their body they can't tell us, that are important for us to remember. Important too that you're managing and maintaining, that they're going for eye exams and those kind of things. because obviously changes in vision occur with age. And there's difficulty with depth perception, detection of motion, people coming in from the outside where they can't see them. There's a loss sometimes of that side space. And so keep those things in mind as we're being caregivers and we're dealing with them, is trying to come up in front of them, making sure they see us, making sure we're being loud enough that they hear and understand everything we're saying, because their response in fight or flight or all of those things are definitely going to be related to vision and hearing for sure. There's changes in the interpretation of sight, sound, and smell. The changes in taste are huge because it is so hard when your loved one is a dementia patient that will eat. But these are very real, these taste changes. And so it's important to keep in mind that you may have made spaghetti, and it may look like spaghetti, and it may smell like the spaghetti you always made, but when they taste it, they may taste salt. It depends on their taste buds, and just, unfortunately, we have to adapt. What we do know in the world of medicine, taste buds change, not only in dementia patients, chemotherapy patients experience this, we have different patient populations that go through the same thing. What we typically see the least amount of change in are the taste buds of sweet. So they typically eat sweets, right? So when you have a loved one that is struggling and you're struggling to get nutrition and those things, and then keep that in mind, because if it's breakfast, try to have syrup. Something they can dip in, something that they can, or jelly, right? Things that are sweet and soft. Try to make it that way if you need to in order to try to help encourage you to eat. Fruits are a great thing because they are naturally sweet. So trying to keep fruit and those things off, and that is something they will eat. And then the truth is, if you can't get them to eat anything, and my grandmother, the last year of her life, I promise you, I think, survived on Bluebell vanilla ice cream. And so, and that's okay too. Calories are calories. If you're at that stage, I mean, if Bluebell ice cream, a little bite is what you want for breakfast every day, then I wouldn't find it personally. But it is important to try to get protein and those things into. And so the other thing is trying to find some protein supplements and making a malt, right? Or those kind of shakes or those things. Or trying to get protein in a juice drink, you know, where you've juiced or blended fruits and those things. So those natural fruits and sweeteners are there. But just try to keep in mind sweet, because that seems to be what they will continue to eat. Interpretation requires higher level thinking. So how we develop expectations from previous experiences, that's what I was talking about. If you're at the doctor's office, we know what to expect, right? But they don't. So there's not that previous experience background necessarily for them to pull from. And so it is best if all of us try our very best anytime we're going anywhere, doing anything, try to be like, we're going to go back on that walk again. We're going to go back to that path. I mean, almost like you would a little child that you're trying to repeatedly explain to make sure that they remember and that it's a good experience for them. Because if we can try to, I don't know that they'll remember it, but they'll know that you've explained it and that it's safe, right? And you're their safety, right? And so distortions in interpretation can be mistaken as hallucinations or delusions. And so that's important too, because if they see something from the side and they can't make it out clearly, their vision is affected. If how they see or hear things, they can start to be treated or medicated even if it's severe, as if they're having hallucinations. Now, hallucinations are possible. They are with delirium and these things and with dementia. But I think sometimes we have to be very cautious we're not jumping to those conclusions and that we're not paying attention right to visual and hearing and auditory changes and those things that are happening as well. Okay, language. For the left side of the brain, it's typically lost. So that's your main, in time, with moderate and advanced disease. Your vocabulary, your ability to word find, right? Comprehension of those things, speech. If they're bilingual, and we know there's a large, dementia affects all races, but there are even some higher proportions in Hispanic cultures and other cultures than we see in the white population. They may revert to their native language. Relying more on nonverbal communication and social isolation can exacerbate this. So the less that early disease, it is good to get out and move. My father, let's use him as an example. It is good for them to go out to lunch. It is good for them to go out to dinner. It's good for him to order for himself. It's good to try to keep activity, stimulation, and those environments going to try to continue that. Unfortunately, we know that this is a very isolating disease, right? So coming coming to places like this, activities where you're involved and they're involved, and those things are incredibly important if you can get them out of the house. But it's a lot, right? To load up and get in the car and get somewhere can be a lot of work. And so, but as best you can, it's best to try to keep moving. But unfortunately, no matter what you do, the loss will come with time. But the right side of the brain remains more. That is your chit-chat side. How you doing? I'm fine. So many of the patients I see that have dementia, they're feeling like, if you walked in there and just talked to them for a minute or two, you're not going to even know. You're not going to realize what I'm going through. And it's so true, because those natural rhythmic responses, that social chit-chat is totally right there. It's when we need that more in-depth comprehension and understanding they start to struggle. A lot of the patients that I know have dementia, and when I more so grab the history from the family, I'm in a total social chit-chat with them, because I don't want them to start to find fear. Because if I start questioning, where do you live? Where are you? Do you know where you are? Do you know who they are? They're going to start, when they can't come up with it, there's that defense, and they start to get anxious, and they start to get scared, and they start to look for you, right? Your family, those kind of things. And so I'm in a total social chit-chat and find rhythm with them. Music, poetry, prayer, these are huge, because many patients can still pull back the words from a song, right? They can still sing at church, even though they struggle to have conversations with you at home. So a lot of times, this yet again is the emotional connection often, I believe, with that as well. But it also is that right side of the brain that keeps that rhythmic language there. And then unfortunately, these words also sit in that area. Right? And unfortunately, we get them. And they're usually aimed at those they love the most and that are closest to them. Thank goodness, because you don't want to go into the community center. So at least they're targeted at us, hopefully, most of the time. So the BPSD, behavioral and psychological symptoms that are associated with dementia. I've been going through them at a range, but it's the psychological, psychiatric behaviors that occur with dementia. Verbal, vocal, or motor activities that are not just purely related to the needs of the individual or requirements of the situation. So they're not in proportion with what's going on around them. 90% of patients will experience BPSD. And so what we're talking about for hyperactive symptoms, agitation, wandering, for hypoactive, depression, hyperactive again, psychosis, screaming, violence, or attacking or fighting you. These are all, unfortunately, all too common and all hard to treat. Agitation, wandering, psychosis, screaming, and violence, all very hard to maneuver in that moment because you panic and you don't know what to do. My first reaction, when I was trained, when I've been dealing with dementia patients in the training, is start to whisper. Because if you start to whisper, you have to make sure they can hear you, but it brings your level of agitation down. So if they are screaming, it helps you to suddenly take it down a level, because our natural response when someone is screaming at us is to scream back, right? And so if you can consciously try to be like, okay, listen, just for a second, let me get down here, let me take this down a level, they're screaming. Okay, now I hear you, I'm so sorry that I've upset you. I'm going to give you a minute. What can I do? Is there anything I can do to help you calm down? Does that make sense? But trying to bring yourself down with it. The wondering, obviously, is so hard to deal with. I'm going to say this right now, because I don't know if I have it later in here. As we use medications, I hate to medicate people for these kind of things. You just do. And you feel guilty about it, to be quite honest, when you're a caregiver, because you think, I don't want to have to, I'm not trying to knock you out. I'm just trying to just get a good night's sleep, because we haven't had a good night's sleep in 2 weeks, right? And you're just trying to balance it and figure it out. What I would say to you, though, is to keep in mind, they want to be at home. And you're trying to make that happen. And you need to do whatever you have to do, so long as it's safe for them. So if it's a medicine your doctor has prescribed and said it's okay to give when he's getting agitated, I don't want you to feel bad about giving it. It's okay to use these medications. Especially if they're trying to wander at night, if you're trying to get them to sleep, they're trying to get them to rest. You've got to do what's safest for them and for you, and you've got to be able to do, if they really wanted to be at home before all this dementia. They got to the place where this is going to be a real struggle to keep them there. Then you know it's okay with them if that's what you need to do in order to try to take care of them in the home. And so you need to be able to do what you need to do in order to try to do what's best for your care, their care, and your environment. Also calling on others. When my grandmother first got sick, I felt like the church family and people and friends and neighbors came a lot more. But once you're sick with a disease for 15 years, the number of people that keep stopping by really dwindles. Number one, they're getting old and sick themselves, right? I mean, they don't have, they're trying to take care of their loved ones that have heart disease or renal failure or dementia too. I mean, you start to lose the numbers of people that you have to help. But don't be afraid to call and ask for help. I felt like that's one of the biggest things that I hear is everybody says, oh, let me know if you need anything, but then nobody ever does anything, right? And the truth is, though, we as caregivers are just as guilty about not saying, you know what I really need? Someone to come over from 1 to 2 on Thursday. Could you and your husband do that? Could y'all come over for like an hour? And that's okay to ask people to do. People really mean it when they say that. And they may say, I can't do that on Thursday, but I could do it on Friday. Well, that's okay. You know what does that make sense? I just want to encourage you that people truly do want to help you. It's okay to ask for it. So the DPD symptom clusters, agitation, which is pacing, repetitive actions, dressing and undressing, restlessness and anxiousness, psychosis, which is hallucinations, the mania, pressured speech, euphoria, irritability, aggression, physical, verbal, aggressive reactions. But then there's the hypoactives, which are equally as frustrating if you're a caregiver, because they're withdrawn, they're amotivated, they don't want to get up and do anything, and you just want them to try to keep going. They don't want to eat, they're sad, they're tearful, they're hopeless. You feel, so sorry. You don't fall over, right? Okay. You feel so guilty too that you can't get them to eat, you can't get them to do, you can't get them to be involved. And these are equally as frustrating to try to manage. So talking through those things with your doctors, and that is incredibly important. And be sure you include those hypoactive symptoms, because I feel like so often people leave those out. They complain about the restlessness, the agitation, all of those things. And when I say complain, I don't mean that as an ugly word. That's what we use in medicine to describe when people tell us what's wrong. But they often leave us the behavioral deficits they leave out. So behavioral excess, disruptive vocalization, aggression, these active, but behavioral deficits, lack of social interaction, lack of self-care, those kind of things are also incredibly hard to manage. 6 phases of change experienced by people with dementia. So obviously, this is true for patients and caregivers. There's a recognition, there's periods of denial, anger and guilt status, coping, maturation, separation from self is typically what we start to see in very advanced disease states with dementia. The pharmacologic treatments that we have, they're not very good, right? Nothing treats it, nothing makes it well. I mean, you hope that it kind of delays progression, especially when caught early. And I certainly recommend using them. Don't get me wrong, I'm not saying, but I think that all of us wish we had a pill that when they took it, it would get better, right? And unfortunately, we all know if we've dealt with these medications that that's not typically what we see. We just hope they're slowing down progression. But it's not reversible. Management's aimed at managing symptoms. There are a few dementia symptoms when people show up with dementia symptoms that are reversible. There are some B deficiencies. So thyroid deficiencies can affect short-term memory loss. So all of those things need to be being managed. It's like 15% of people that present with their initial symptom we describe as dementia that actually is some reversible form, but that's important to know, that those things do exist, and your doctor should be checking for those things. When my dad first went, his thyroid was undetectable, and so I was really hopeful that that would make a difference. It has made a difference in progression for sure, but he's still pretty forgetful about things. But anyway, drug therapies. Acetylcholinesterase inhibitors, these are the most common Aricept. You may have Exelon patches that you're using. The monoclonal antibodies, these are new. Still no magical results that everybody's saying, okay, we're going to start to use these drugs, and so we're not seeing them still used very much if we're being honest. And then NMDA receptor antagonists, which is like your Dementia, which is typically used more with moderate to advanced disease. The other pharmacologics that we use, so you'll see a lot of antidepressants, very common, to try to obviously keep people's spirits up, especially early stages, but once you're on it, you often continue on it. But the depression that comes with finding out that you're the person with dementia, I mean, that's so incredibly natural and normal. And using an antidepressant to lift your spirits and try to keep you upbeat, I think is important and is good. Along with the advanced disease course, sometimes those are fine to continue. Sometimes people ask me, is it okay to stop this once they're bedbound? And they're absolutely, and in that case, if they're nonverbal and those things, you can try to stop them, but it may change how they eat. It may change the smiles that you get, right? And so you may not want to, okay? People ask me that too a lot about Aricept and Dementia. I keep those medications going, so either until they don't want to take them, but so long as you're verbal, I absolutely keep them going, okay? Once people lose verbal abilities, I leave that up to a family, but without those medications, could progression become more rapid? It could. When people are no longer verbal and they're that advanced in the disease course, sometimes families would say to me, which they hate to say out loud, it's okay if it goes faster at this point. This is not the way they would want to be anyway. And they feel guilty about saying that. There's no problem with that. Hopefully you've had those conversations, or hopefully you know them well enough that you know the way that they would, what they would want, what sort of like they would want prolonged or not prolonged. Does that make sense with these medications as well? Antipsychotics. So these are the ones that we typically use for more agitation and restless symptoms. So those that are wanderers, those that are insomnias or wandering at night or up at night and those things. Risperidone, Seroquel is really common. I like this drug actually for those things. Zyprexa, haloperidol, and Abilify. Haloperidol is shorter acting. A lot of the other ones are longer acting medications. These are the ones that I wanted to say, like I said earlier, you shouldn't feel guilty about using if you need to, because you want to try to keep your loved one at home and you have to sleep. You can't work 24 hours a day, 7 days a week. None of us, right? Anticonvulsants, so you will see us sometimes use things like Neurontin, carbamazepine, valproate, trileptal, and Topamax. These are all things that sometimes we will use to manage symptoms and restlessness, agitation, and those things. Trying to use, these are typically considered less sedating than this category. And anxiolytics, we don't use those a lot, don't use them a lot in dementia patients unless you have to, unless you really need to. Or if someone has a history of anxiety. So if you have a patient that has dementia that has previously had a fair amount of anxiety even at baseline when they were able to use their front filter and all those things, well then obviously these medicines may be perfect for them. Not because they have dementia, but because they were an anxious person that has dementia. Does that make sense? So antihistamines, so Benadryl and Atarax, we will use those sometimes as anti-anxiety. They are anti-itching, they are sleep. You know, some people use Benadryl for sleep. You should not use these without talking to your own physician. But Atarax is being used more and more, actually even in younger patients, like teenagers that show up with anxiety, where we don't want to start them on benzodiazepines and those things that are more addictive. We will try periods of Atarax and those things to see they can kind of decrease that restlessness and that anxiety level. Appetite stimulants, Megace, Remeron is an antidepressant that typically we can give at night that is also an appetite stimulant. It's also supposed to help a little bit with sleep. And so it's kind of a 3-in-1 drug that you'll see a lot of dementia patients on. Megace is good too if you don't have a history of blood clots, those kind of things. So everything has a side effect, but if they're not eating much and you want to try appetite stimulants, it's absolutely very reasonable to do. But as I said earlier, trying to make diet modifications, I recommend first, trying to sweet things and all of that kind of stuff. Sleep therapies, melatonin, trazodone, benzodiazepines, are things that we certainly use. Amphetamines, so for those patients that don't have the get up and go, those that are becoming apathetic, withdrawn, don't want to move. This is Ritalin. Well, so it can, when you don't have ADHD, you use it in kids with ADHD, right, to try to take them down a level. When you don't have that, to try to boost you or give you that extra bit of energy, you can use a low dose Ritalin, like 5 milligrams in the morning. It only has about a 6-hour half-life, but it could give people extra bit of energy in the morning. Sometimes people will use 5 milligrams twice a day. Now, if you have any experience with these types of drugs, though, you know that if you use them every single day, their effects wear off. So a lot of times people will do a holiday. They may do it Monday through Thursday, take off Friday, Saturday, Sunday, Or they may do it for 2 or 3 weeks in a row and then take a week off. It depends on what your schedule's like, what you have going on in your life, those kind of things. But you are able to do them. You can't use Ritalin if you have a history of seizures, right? So there are complications, there are obstacles sometimes with them, but there are things to keep in mind. Non-pharmacological therapies are huge. Acupuncture, aromatherapy, music therapy, massage and touch therapy, and then obviously psychosocial interventions like exercise therapy. Finding what works for you and your family. So we are not in a part of the country where acupuncture is used a whole lot, but are there acupuncturists around this area? Absolutely. And have I had patients that have responded very well to such therapy? Absolutely. So it's stimulation of specific acupoints along the skin of the body, application of heat, pressure, and then sometimes needles. So it's not always needles. I think that's what most of us think about. But if you talk to an acupuncture specialist, they don't always do that. It's Chinese medicine. But when it's one less pill and it actually helps with some stress, anxiety, relief, it doesn't bring back memory, but it can help with some of the symptoms. And so it's something to consider. Aromatherapy. How many of you have ever been to a day spa and you walked in and you smell the lavender and they have the music going and you're like, well, at least me with a 5 and 7-year-old, I'm like, nobody has to massage me. If you just put me on a table for an hour, I'll take a nap. Like, this is so nice and peaceful. I'll just rest. And that's kind of the same purpose, right? Aromatherapy is using lavenders, bergamot, lemon balm. There are different ones. I am not an aromatherapy specialist, but if you have friends that do this, they know exactly what they would recommend in those things, and this is not going to hurt them unless they're COPD. Okay, don't keep in mind your other disease processes. Don't start a bunch of things that smell if you have COPD and your airways could react, right? But with in these calming environments and these things, these are certainly something that you could do in the afternoons or evenings, start around 6 p.m. Music, calming music, aromatherapy things, these things to try to bring things down a level, to try to relax them and you, right? At the end of the days. Music therapy. I have a lot of slides on this because there's so much data on how helpful this is. So music has the ability to bring you back in time, right? To bring you back to dates, to bring you back to events, emotions with memories. And like I said to you, the emotion can still be present even when the full memory is not there. And so I think music therapy is huge. My grandparents had a record player is huge, right? Playing favorite records and those kind of things. So musical memories are often preserved longer. It can revive a memory of feeling. It can take down anxiety and calm. It also, though, can pump people up. So playing, if you have that loved one that is not wanting to get up and do, music is also motivational in that way. Get something that's going and clapping and that thing. And sometimes people have a hard time at least nodding to the beat to go. It's interactive. Live music making as well, obviously. That's probably not something often many of us would do at home, but coming somewhere like here, activity centers and those things, obviously there's huge there. And finding out if they do go to those activities, was there something that they did that day, a music, a song, that really got them involved or really made them happy? It's important to know what those triggers are, right, for you, because it's something that you can do. That's something that you can mimic at home. Self-expression and interactions, it's easily accessible. And voice and those kind of things are also easy to do. Artistic creativity is unimpaired in the early and middle stages. And so sometimes there are therapists. You don't have to have a therapist. Of course, everything that's been studied is going to have a therapist involved because that's how it becomes a study typically, right? But obviously, I don't believe that those things are absolutely necessary. They have been shown to reduce the medications that are needed for sedation and those things. They've demonstrated a reduction in baseline levels of agitation. And that's why I was saying here, knowing the songs they responded to is important. And the benefits can last for hours. And the benefits obviously don't have to be verbal. So even after they've lost the ability to verbalize, there can still be that nodding, clapping, and all of that, the appreciation of the music. And even hours after the intervention can still be beneficial. Number one, the calming effect of it. Number two, you may be exhausted. You've been sitting up, clapping, and enjoying yourself. You may get those benefits as well later on in the day. it's not about teaching someone to play an instrument. We're not talking about a music lesson or music appreciation, right? We're talking about doing things that would help to benefit them and help benefit you if you're managing their care. Massage and touch are huge. And this is important anytime I feel like when I'm talking to someone that has moderate or severely advanced dementia, is making sure my hand is on them so they understand I am gentle, I'm not here to move too fast, and I'm trying to keep their attention where I am. The goals obviously are to reduce depression, anxiety, aggression, and other behavioral symptoms. Expressive touch, like patting or holding someone's hand, that's important for us. And there's trials that I put in here, some of the data that is helpful with even the most simple. But if you've been with your loved one and you go to a public place, even just holding their hand, I mean, is huge, right? To help keep things calm. Art therapy also improves social interaction, self-expression. There's some exercise. There's focus. They have to stay up. They have to stay involved. All these things are great to keep the mind moving, memory and bringing back memories and those kind of things, but also physical movement, like we're talking about. And art therapy is also important, even if you think about it, even how we do fine motor, right? So it turns back to, are we feeding ourselves? Are we eating? There's so many things that play on to one another that are important to try to keep things, maybe like, he wouldn't really like art. Yeah, but if he's doing fine details and there's fine motor movement, that's important later for us to continue to use our utensils and to continue to feed ourselves and all of those kind of things. Animal therapy, I'm a junkie. What can I say? I had to include this one because it just makes people happy. And especially like the therapeutic groups, you know that those animals are so well trained. But you may notice that too with your loved one and their pet. So if you're at home and y'all have a dog or y'all have a cat or they have their own animal, there are so many times in the hospital people ask me if they can bring their pet. And I get it though, because it's what calms them. Them just sitting there, they sit in their recliner, they rub their, you know what I mean, they sit there and pet them and it just brings peace. Physical exercise. If they are still able to safely do so, I cannot say enough about this, and I'm sure you all know it, and it's so hard in the summer when it's 100 degrees outside, right? But to try to do gardening or music and dance, swimming, walking, even seated exercise, and if it's, it doesn't have to be like Richard Simmons, right, so doing it while you're seated. But I'm just saying doing activities, rolling the ball, passing it back and forth, just doing something that keeps them moving. And I'm talking about like a huge beach ball, you know, just kind of keeping those things moving back and forth. You can have a TV on and be doing other things, but just keeping movement and keeping activity, and those things are so important. Later, it's important too to try to keep, if you don't know how to help them change positions, if you've never had experience with an aid or those things, please reach out to those of us that do hospice or even home health, because we have aids, and I believe it's so important that we try to get you, if you're getting to that point, even home health probably would qualify for it, but to try to have someone that can show you how to safely move somebody, because learning how to transfer someone safely without breaking your back, learning how to help someone stand up safely, learning how to adjust a patient in a bed with a draw sheet is so much different than trying to lift them and pull them the way we would all naturally do it if we don't have training. And so it's really important that you know how to move them and help them to move, and to try to do it safely for you and for them, but also to not just give up and say, okay, we're just going to stay in the bed because I don't know how to do this. Trying to reach out and asking for help if your loved one is getting to the stage where you need these mobility challenges and you need us to help you. Let us try to teach you or reach out to us. I'm sure the Alliance would do to try to get in touch with any of us to kind of say, I don't know what to do, and now I'm having trouble getting her out of the chair. Can I not get her out of the chair? Can someone come out here and show me either how to do it, or are we at the place where they would tell me it's not safe for me to do it anymore? But I don't know. And so who can help me? But reaching out for those things. And balancing while standing or while sitting. So sitting on the edge of the bed, just holding themselves upright, uses all your core muscles, helps with bowel movements, helps with all of those things. So it is important, even if your loved one is more so at this place of bedbound, to try to still even just sit up for a couple, during the day for a little bit of time. And it doesn't have to be long. You can do this for 10 minutes and do it 4 times a day, where you just sit up on the edge of the bed and you're moving. But movement is important. And also, when you're at a place where you're so weak that you're in the bed, it's exhausting. So it's activity for them, it's getting them up, it's laying them back down. And doing that a couple times a day will also help throughout the day to allow them to turn around and rest too. Because when you're just in the bed, it's hard to keep activity and motion going. Allow time. It can take 5 times longer to process information than it takes for an elderly person without dementia. So give them time, right, to respond and to hear you and to see you, because you know that they hear you. Don't be afraid of long pauses. Don't assume that they don't understand just because they don't respond straight away, or that you may not get a response. I remember my great uncle had dementia. We were at a party on July the 4th at his house, and he had Dr. Pepper sitting in front of him, and he was advanced. He didn't speak much at all. And I said, Uncle Butch, is that your Dr. Pepper? And everybody was around us talking, and so we all started talking. And a few minutes later, he put his hand on my arm and he goes, yes. But it felt like 5 minutes later to me. And I thought, he's been sitting there that whole time, processing what I just said and trying to get it out. I probably had 8 other conversations in the meantime. But when he said that, I said, oh, perfect. Let me go put it back on ice, because I bet it's just been sitting there. Do you know what I mean? And so making sure that he knew I heard him too. But I believe so much that even though their time is so different, their timing and their processing, like I said to you, I believe they understand so much more than you simply give credit for. Allow quiet time, and understand the complications of time-bounded sessions. So the beginning and the ending they may not be prepared for. So what I mean by that is, if you're doing something, it's important if you have the opportunity to say, we're going to be done in about 5 minutes, we're going to be heading back home in a few minutes. They don't realize necessarily when you're about to go and when you're going to. So it's important too when things are ending. Just like a kid, right? That you sometimes may have to say, hey, we're going to be going here in the next hour, we're going to be doing this in the next hour. Be sure you're in front of them, be sure your hands on them, you know what I mean? And then the same thing with afterwards. And this is super important for you to remind us of as caregivers, when all these things I'm telling you are good for you to know, but they're also really good for you to try to remind any of us that are taking care of your loved ones, right? That it's important to say, we're about to be going, or all of those kind of things. Do I have time to go through the rest of this?
Yeah, you've still got a half hour left.
Okay. When it's personal, all bets are off. We're going to start talking real quick about advanced directives. And I'm going to tell you what I believe is an incredibly honest approach and what you need to know. Because when it's your loved one, you need to know this. And this is a conversation you never want to have. And I hope that you don't have to have it again. I hope that I give you enough information right now that you can use it to make these kind of decisions and understand these situations when it is the time and when you're approached with them. So an advanced directive is an outline of what you would or would not want when you become very ill and are unable to make those decisions for yourself. Medical power of attorney is who will make those decisions for you, who verbally should speak on your behalf. And we're going to talk about both these things. So withdrawing or withholding medical interventions are considered the same things in the eyes of medicine. So to not ever put someone on a ventilator as the same as being able to take them off of it. If you never started it, it's the same as saying I started it but I have a right to stop it, okay? So withdrawing or withholding is the same thing. So when it comes down to decisions, we are typically talking about advanced dementia, but these things I'm going to tell you have to do with any advanced disease state, okay? If you have an incurable condition and you're in an advanced disease state. Code status. By the time that we're grabbing your advanced directives and we're talking with you about whether or not you would want chest compressions, which is cardiac interventions, this is a DNR, or DNI, which is intubation, which is where they put the tube down your throat to breathe for you, okay? What we really, if you're an advanced disease person, are asking is, how do you want to die? I say that because if we're talking about putting you on a life support or doing chest compressions and you are in an advanced disease state, typically the chances of your condition being reversible if I put you on a life support machine is almost non-existent, right? It's not going to change it. So if you said, I am a person that if I have advanced COPD or if I have advanced dementia, I would want to die in an ICU on ventilators. I want people doing absolutely everything they can do. Then you are going to be a full code. We are going to be putting a tube down your throat, and when your heart stops, we would run in there and do chest compressions and try to bring you back. What you do need to know is that we did studies on this in the 70s. We did them again in the early 2000s. And what we found is that if someone is in a hospital in codes, they need resuscitation, about 30% of those people will survive the code. About half of them, 15%, will survive to ever leave the hospital. About half of them, 7%, will ever return home. And that's of all ages. That's if we have children all the way to the elderly. So you can imagine that those numbers, when you're advanced age with advanced dementia, are minuscule in the numbers that we actually have that can survive and to ever make it back. We're not very good at life support and resuscitation. Not unless you're 45 or 50 and you have a massive heart attack. We can get you on a vent and we can get a stent in there. It's reversible. We can get you off. You can walk out of that hospital. That's a reversible situation. The problem is that often when people are dying of advanced disease, it's irreversible. And that doesn't matter if it's COPD, if it's renal failure, if it's heart disease, or if it's dementia. Then if we can't reverse what's causing the end of life to happen to you, then you can't survive it. And so that's when we recommend a DNR, DNI. If you have a reversible condition, we recommend you be a full code, okay? But when you don't have a reversible condition, this is why we start to have these conversations and make these recommendations. And typically by the time that we're asking you about that, we're saying, would you want to be in an ICU on machines when you pass? And there are people that do. They say, I want people doing absolutely everything. But the majority of people would say, no, if I know this is the end, I don't want ICU visitation hours for 2 hours a day. I want to spend the last days I have with my family, either in the hospital with drips and IVs and nurses and medications running, but I don't want to be put in an ICU. I want my family at my bedside holding my hand and with me, or in a hospice or in a home environment where your family is with you and you're comfortable. And so, but those are all DNR states. Those are do not resuscitate, do not intubation states. They're not in the ICU, okay? And so code status is part of it, but the truth is by the time that you can't tell me anymore, this is typically what I'm wanting to know, is if it was the end of life, how do you want to die? Do you want to be surrounded by your family? Do you want to be in an ICU? And that's not my job to say which is right. I'm okay with whatever you choose, but it's important for you to know what you choose and to put it down on paper so your family knows what to do, because typically it's not you I'm coming to, right? It's your loved ones, and they have to make the hardest decisions in the whole world. And then they have the guilt no matter what they do, because you always, if you do everything, you say, oh, I wish I wouldn't have put him through that because you lost him. And then if you don't do everything, you say, I wonder if I'd have done all that, would it have been a different outcome? We don't get out of these decisions without second guessing ourselves who we're the ones left behind. Never. You always are going to second guess. But it does help when you say, we had this conversation, I know what they wanted, and I know I did what they wanted. I know I did that. And so I have peace there, okay? Artificial nutrition and hydration. Artificial nutrition. Yeah, let me see if I can pack this a little bit. I'm sorry, because I'm just keep talking, so let me see. I may have some slides. Okay. What does DNR, DNI mean? I just went through that. So DNR, cardiac resuscitation. DNI is intubation. Now, we will sometimes break these apart and say, you can be DNR with DNI, DNI without DNR. But I'm going to be very honest with you about this. If you resuscitate someone's heart and you're not giving them oxygen at the same time, then if you get their heart back, even just temporarily, they didn't get enough oxygen to the brain. So that doesn't make good sense to do, right? Because they were likely to have a brain injury. If you don't resuscitate their heart, but you're giving them oxygen, that's not going to keep them alive without their heart. So if you want it all done, you either do it all together or you don't. The only exception to that rule is if your loved one is already on a ventilator. They're already intubated, and you were to say, at this point, if their heart stops, don't run in there and try to shock them and bring them back. That's the time of cardiac DNRs. Does that make sense? I know this is complicated, but I want to make sure everybody understands. The intervention of life support, I just went through a second ago, reversible versus non-reversible conditions. If your condition is non-reversible, then a DNR, DNI is typically recommended. But if you have a reversible condition, you should be a full code. Hopefully we can reverse reverse whatever's going on with you, and we can keep you going, okay? The burdens of life support and resuscitation. Sedation. So if you are advanced disease and you are getting worse, sometimes you do believe very strongly that if you're going to die, if we put you on a life support machine in an ICU, that you probably would have more time if you never went to the ICU with your family. And the reason is because the second we put that tube down, we have to sedate you. So then you're unresponsive in an ICU. So are you really gaining more time with your family or more alive? Not if, when the other room, I could have not sedated you and allowed you to still have a little bit more times where you still woke up a couple times and kissed them on the cheek or those kind of things, which you're not able to do once we've had you sedated. Isolation, which is the visiting hours of the ICU. At ETMC right now, it's 2 hours. You can go between 1 and 3 and 8 and 9 at night. And those are the only 3 hours a day. The pain and suffering that goes along for your loved one that has to be on the life support. So it doesn't go without its burdens. Now, if you're reversible, I'm going to make you isolate a little bit and sedate you because I think you're going to end up with more time on the other side of that, right? Because your condition's reversible. Okay. Artificial nutrition and hydration. This one is super controversial, okay? Feeding tubes and IV fluids, okay? They can be helpful in certain situations and they can be harmful. Depends on the situation completely. They were originally developed to provide temporary support during acute illness. Dying patients, if they're truly in the advanced stages and they truly are dying near the end of life, they deny hunger, and we typically can keep them comfortable with oral hygiene, ice chips, those kind of things. That is at the very, very end of life. None of us I can feed until the very end of life. When I have people on hospice care, even if they have a feeding tube, I'll pour a can of food in there, and an hour later I come back, and I pull back and I get the whole can, because the gut shuts down. In the dying process, the stomach shuts down. Our bodies were, I believe, I'm Christian, I believe God made us very smart, and I know He made us long before feeding tubes, and that our gut shuts down. When you're in an ICU, if you ever had a loved one that was in an ICU for a temporary, the first 2 or 3 days they're in there, we often don't feed them, which people often worry about. But that's because they're so sick that they can't digest the food anyway. So we keep them on IV antibiotics, we keep them on IV fluids and IV drips. About day 2 or 3, we drop the feeding tube and we start trying to feed them. Because by that point, we believe they should be improving and their gut should start functioning. But the first couple of days, families often are like, why aren't you feeding them? Why in the tube then? And it's like, well, their gut is not going to function right now. Because when you are dying, when your body is getting that ill, the gut is one of the first organs to shut down. Okay, and so we see that they don't eat. That's important though with our dementia patients because oral foods and fluids should be encouraged. They should be offered for comfort and pleasure, even all the way till the very last breath. But artificial nutrition and hydrations at the end of life have not been shown to extend life. Feeding tubes, if you are at a place where you need to do a feeding tube because they are not eating enough, but they can still eat, so sometimes we will use them as a supplement. So they will eat some, but they're not eating enough, but they're still hungry. So you'll say, Parkinson's patients are a huge factor in this one. They lose the muscular ability, right, to swallow, but they may want to eat some, but then they don't eat enough till they get full. So many of them we end up putting a feeding tube in because they'll say, I'm still hungry, you know? But the natural decline of dementia is often their appetite drops with time, with advancing disease. And by the time, if they're not eating enough to maintain their nutrition and those things, for some people that's okay. It's like, I know they're dwindling, but they're getting enough, they feel full. I'm content. They're happy. We don't have to do a tube that they may pull out and all of those kind of things that the complications go with. If you're at the place where your loved one with dementia is aspirating, the problem is that feeding tubes have not shown to decrease aspiration because of the feeding tube is all liquid nutrition. Aspiration is where some food goes into your lungs. So at the back of your throat, you have your airway that sits in front of your swallow tube, right? And so when you swallow and you're trying to eat, it can go down the airway if your muscles here aren't strong enough to manage that. The problem is when you do liquid nutrition through a feeding tube, many of these patients are bedbound. So to be changed or turned, they have to lay flat. When they lay flat, liquid nutrition that's continually running in that feeding tube rolls up, and so they can still aspirate. And so, unfortunately, we have not found that feeding tubes decrease the risk of aspiration. Now, that doesn't mean they're wrong to do. Sometimes families say, I still need to do them in order to feel like it. But but you just need to know if they end up with aspiration pneumonia after you've done a feeding tube, you did nothing wrong. That's unfortunately part of the disease process, and that's expected. So with feeding tubes, do we use them? There's a book called Choosing Wisely. There was a campaign done years ago about people with advanced dementia and whether or not you should do feeding tubes or not. It goes through all the complications, the hazards of pulling the tube, infection, and continued aspiration versus whether or not they're actually beneficial. Those books are available. I know we have them through hospice if anybody wants to read them. It's interesting, but the moral of the story is that if you're early enough in the disease process, that there's something that they can't eat enough, and you feel like you need to do that to improve their nutrition, or if they're having wounds, do you know what I mean? And you're earlier in the disease process, then to do a feeding tube may be your answer, okay? To help supplement their nutrition. It is almost impossible, though, if people are earlier in the disease and they're still verbal, for them to understand why they can't eat by mouth. So the other reason that you often, with a feeding tube, don't decrease the risk of aspiration is because when your loved one is there, if they're still verbal and they say, but I want water, I want a Coke, I want a Coke, I want a Coke, it is hard all day to say no, 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 not when it's one of the only pleasures they have left, right? And so sometimes you still give them to drink because you do, because you love them, and it's hard to say no, and then they still aspirate. And so complications with feeding tubes are huge. If your loved one is still at a state where they can answer and tell you what they want at that stage, that's incredibly important. But also, asking your doctors at that stage, or your neurologist, or who it is that you trust with your loved one that has dementia, and their opinion at that point is incredibly important too. It's also important to me how you feel about it, because you have to live with those decisions. And I don't want you to live with regret. I want you to feel like I made the right decision and I tried to do the right thing. We did not have to put a feeding tube. My grandmother, she was aspirating, but she had been declining enough that she wasn't eating very much, and that's really common. You know, your stomach can get as small as your thumb. Yeah. So also, when people have some non-commonly with natural decline of dementia, their appetite decreases a little by a little by a little by a little. So they go from like a grapefruit-sized stomach to a golf ball-sized, to tennis ball to a golf ball, and to down to here. So 2 or 3 bites, people will say, at the very final stage, they'll say they only take 2 or 3 bites, and then they're done. And they do that like 6 or 8 times a day. And it's like, that's not surprising, that's not uncomfortable. They're full after 2 or 3 bites, and that's okay. But it's important to understand artificial nutrition and hydration, because this is a really hard decision for families. Artificial hydration, IV fluid. IV fluid should and can still be done so long as there is protein and nutrition going in. Problem with fluid, if you are not eating and if you're not having protein, is that your albumin, which is your protein level, is what helps keep your fluid inside your blood vessels. Once you start to lose protein levels, if we are giving you IV fluid, you swell. The fluid goes to your legs, it goes around your arms, and worse, it goes around your lungs. And you don't want that. And so it is very hard in the world of hospice. I work at the inpatient hospice hospital here 1 week a month, and people often will ask me, why do I not give people IV fluid out there? I don't give them IV fluid because they are not taking protein in. And if you've ever been with someone that died and heard that rattling sound and that congestion, you don't want to contribute to that and make it worse. And that fluid, if I'm giving it through an IV, I can't control it. Now, if they wake up enough to drink their fluid, they can have as much as they want. But I can't, if they're at the very end of life, in the last week of life, I can't give IV fluid. I can't let them drown in it. And their kidneys are shutting down, I can't get it off of them. And so I get stuck between a rock and a hard place. But I never want people to do it because they think I don't want them to die, or I don't want them to be comfortable. That's not at all it. Also, if people are at the very end of life, when it comes to fluid, the kidneys are shutting down as well. And so people will continue to circulate what fluid they have. So most of us, if we were in a hot desert and we didn't eat or drink, we would die within a few short days, right? 2 or 3 days, we would be gone. In the dying process, if you've ever been with someone during their process, often people, it takes them a week to die. You don't know that. They start eating less and less, they sleep more and more, and in the last day or 2 of life, they're often completely asleep. And so, but they can survive 5, 7, 10, or even 14 days without much more, a few little sips or drops, because their body keeps circulating the fluid they have, because their kidneys stop peeing off as much of their fluid. Does that make sense too? And so people often ask me, are they going to dehydrate to death? I'm like, no, not unless it would take them 30 days to die, which it doesn't take people that long at the end of life to pass. They don't live long enough to suffer that way. Thank goodness we weren't made that way, okay? But people don't know those things, but it's important to ask them. And if it's your loved one, there are answers and there are reasons for the things that we do and don't do. And they're all negotiable, too. I mean, I never want someone that, I've had some people, there are some religions that feel very, very strongly about the offering of fluid until the very end. And I have put a little like insulin needle on the skin and give them like 10 cc's an hour, which is almost nothing, but it's enough to make them feel like I'm doing it, and I will do whatever to make people feel comfortable at that stage, so long as it doesn't cause that patient suffering. Dealing with life-sustaining devices. So, removal of a ventilator. People often don't understand this process, but the removal of a ventilator is not suffocation. When people are taken off of a life support machine, we can give them as much oxygen on a machine or off a machine. You can give 100% oxygen by a mask versus on a machine or off of a machine. What I can't make them do is to breathe deep enough to blow off their carbon dioxide. As carbon dioxide climbs, people fall deep asleep into a coma, and they very peacefully go in their sleep. So when someone comes off a life support machine, I quite honestly don't care what their oxygen stats look like. I care that their breathing looks comfortable and that they don't look like they're struggling for breath. And that they have the natural pattern of breath of dying, which is different than us as we're breathing right now. But what I care is that they're comfortable and they're peaceful. Because their stats, though, sometimes I'll take someone off a ventilator and I'll be giving them oxygen. They're going to say, their stats are 99%, they're going to be fine. And it's like, no, it's not the oxygenation, it's that carbon dioxide. They're not breathing deep enough to blow it off, and it's their carbon dioxide climbs. Then they have carbon dioxide toxicity. But it's not a suffocation, and it's not a hypoxia. And if we thought that was true, then that wouldn't be a comfortable way to offer you to let your loved one go, right? So we wouldn't do that. And during COVID, that actually became a little bit of an issue because we had people on such high volumes of oxygen that actually when people decided to quote unquote take them off of life support, we didn't take the ventilator off. We would adjust the pressures and those things to allow them to naturally pass, but we actually left the machine in place because we felt like it could be uncomfortable for them because of the way that disease process has affected the lungs. Does that make sense? So some of them we didn't, depending on how advanced they were. So anyway, it's important though to ask those kind of questions because I think a lot of people don't understand that and they think if they take off a ventilator, then they're going to suffocate to death, and that's not at all what happens. Turning off an ICD. So a defibrillator is a device that many of you may have planted, pacemakers and defibrillators. Pacer helps pace the rate of your heart, so if your heart rate gets too fast or too slow, your pacer can kick in and start keeping you on the rate that it is set at. An ICD is if you have an abnormal rhythm, it can shock you, okay? And so it's important for you, there could be a time that you have to make a decision when to turn off the ICD. So if you have an ICD and that's not in your directives, it's important for you to say, at the point that I'm near the end of life, I'm agreeable to turning off my defibrillator device. And that just, many people before their very last breath may flip into an abnormal rhythm like VTAC or those things, and that's a shockable rhythm. What we don't want is people to be continually shocked as they're passing because that would be an uncomfortable way to go, right? And so this is often a decision that we come to families with. Pacemakers, we do not turn off. So, and actually don't remove. So if you walk through a cemetery, and if the battery is still good, you could hear them, the pacemakers are still going until their little battery life is gone. Isn't that odd? But the heart stops responding to it when your body's naturally passing. And so, you don't have to worry about making those decisions though. Your body makes those for you in the pacemaker is something you don't have to worry about. Okay? Surrogate decision makers. So people ask me all the time, do they have to have a medical POA? You do not, so long as you agree with who your surrogate decision maker is, your legal next of kin is. So in the state of Texas, the number one person is whoever you made your medical power of attorney. So that will supersede anybody on this list. But if you do not have a medical power of attorney, it's spouse. Common law is included in that. There's not a set timeline. Your bills people say 7 years, but I've looked through the law extensively in the state of Texas. They don't outline it. But I will say most hospitals that I've ever worked in have said at least 2 years of living together as a husband and wife with bills and those kind of things intermingled. But common law does stand. Common law does stand in the state of Texas for same-sex couples as well. That's important for people to understand and know as well. Next, in the state of Texas, majority of adult children, they have to be over 18, and it is not the oldest. It is the majority. It's important, if you have 6 children, if you can, appoint one of them as a medical POA, because it's very hard for me to reach in a critical moment 4 people on the phone to ask what they want to do for their mother who's very, very ill. As you can imagine, that is a awful situation and phone conversation. So it's important to have those directives, but it's important if you have a lot of children, and if it's your wife, that's perfect, but if it's gonna be your kids, then if you have a lot of kids, it's important to appoint one of them as a medical POA if you can. And make sure they know you're not trying to pick your favorite. I mean, you're just trying to do, if you need somebody, the doctors, we need one person that we can try to reach out to say, what do we do right now? If it's not spouse and majority of adult children, it falls to parents if they're alive. Then it falls to siblings, their nearest living relative or a member of the clergy. This happens actually not infrequently that we end up down here on this list. The thing is that a nearest living relative or a member of the clergy, they can make you a do not resuscitate, do not intubate, but they cannot take someone off of a life support machine or make decisions about like that, not putting them on. So by default in a hospital, we are required by law to put you on a life support machine. So if you don't have a lot of family, if it's just you and your husband or you and your wife or whatever the situation is, it's important then that you have an advance directive that we have a copy of, that we know what it is, because otherwise, by default, you would end up on a life support machine and pass in the hospital on life support, because that's what we do in those situations. So, and if you have medical POA, make sure it's up to date. It's not your ex-wife, it's not your ex, I mean, unless that's who you want it to be, okay? Because those situations happen as well, right? Common law, agree they're married, they live together as husband and wife, and they hold out to others that they're married. And so that's important. So palliative care. This is palliative care, the best, one of the best. It's an old diagram, but it's true. When someone is diagnosed with a chronic illness, then initially curative and life-prolonging treatments are the majority of their care, right? But as you continue along that trajectory of illness, the number of curative and life-prolonging treatments you have decreases with time. And the number of palliative interventions that we start to use become more and more. And that's even true of your COP doctor or your CHF doctor. They're adjusting your medications, but they may not have very many more meds that they can add. Same thing happens with dementia, right? Aricept and many of these things. So we start using more palliative programs. Often patients will transition to hospice program. I often put bereavement on here as well, because I do work with a hospice at East Texas, and we do have a great bereavement department and program if you ever need to take advantage of that department, and you don't ever have to have been on hospice to do that, to take advantage of that. So if you were to lose your loved one suddenly, or you know someone in your church who did, and they need extra support, I welcome any of them to reach out. Okay. I spoke for a long time, I'm sorry. But I hope you learned something. I hope it's hey Maggie.
Could you just explain the process that you go through when you evaluate one of your dementia patients and talk to the families, and also how people can access your outpatient services?
So for palliative care, we often, the majority of our patients we see while they're in the hospital. So once they're during a hospitalization, there's been an acute event, and typically we are called in. We are consulted by the physician, so a family has to request that we come by and talk with their loved one, or the doctor themselves will call us, and we come by and talk to you about, okay, our job is to look at your situations. What was different with bringing you in the hospital, and how does this change your world going forward? For some people, it may not. It may be that this is one urinary tract infection, we're going to get antibiotics, we're hoping to get back to baseline. For other people, they fell and broke their head, right? This can change everything. So, or it's a bad infection, and sometimes if you're a person that was just barely holding on to your ability to walk, now they're going to be wheelchair bound, right? So our goal is to try to help you to understand what your options are in regards to rehab or home or support, to try to help manage those symptoms and answer any of your questions that you may have about that point of where you are as we do the examination and evaluation about dementia, okay, about your loved one that has dementia, and taking into account all their other illnesses. It's very seldom I see that person that just has dementia, right? I mean, people have other conditions, and so that that's important too. So we typically do in the hospital, it does require a physician consult, but we have an outpatient clinic where if you have a loved one that has symptoms or things, agitation, anxiety, pain, that you feel like are not being well managed by your physician, and I don't mean that ugly, they've tried different things, but you would like a second opinion or another perspective, you can always ask your primary care doctor to be evaluated by the palliative care clinic. We are glad to do such. We do not become your primary care doctor. That is not our job. Our job is to be a consultant and another set of eyes in another area of support. And typically what we do in our outpatient clinic is symptom management. Things like pain, anxiety, insomnia, anorexia, depression, all of those kind of things we're glad to do. There may be times that we see and feel like, oh no, your neurologist is a better specialist for this, and we would tell you that. We don't want to be another visit that just complicates your life and your world, but you should know that we are available and we're there to meet with you or talk with you or those things. In the hospital, very often, by the time the doctor calls us in, I'm gonna be really direct with you, because when families request us, it's typically further upstream. By the time the doctors call our team in, typically it's because they believe you are nearing the place of hospice. They're feeling like the disease is that advanced. That doesn't mean it has to be, but that is typically, doctors, we are trained to just get people better and get them back home, right? So they aren't gonna call us until they feel like, I don't think these antibiotics are gonna get them much better. I don't think this is really gonna get them back home. By the time they're calling me, it's usually because they feel like there's something different on this hospitalization, and they think you're gonna be back in that hospital in 2 or 3 weeks, that you're getting to that place of disease burden where you may be back and forth. But there are times, my intention is to see people further upstream, but typically those are often consults that are initiated by social work or the family or the nursing staff for those reasons. Sometimes our consults are initiated by speech therapy because families are trying to make those difficult decisions about feeding tubes that I was talking to you about. And like I said, everybody's different. So sometimes just meeting with people and talking through exactly where they are. My job is not to meet with a family and tell them what to do. It's to make sure all your questions are answered and you understand exactly where we are, and to be very honest with you about what we're saying as the physician team and what your options are. Okay? That's how we do inpatient, and that's how our clinic is as well. We are in Tyler, we are expanding it as of August into Longview area as well, which we haven't been in that. We've been here for 13 years, or 14, I've been here for 14 years. I came from Alabama to start palliative care here, and so we started 14 years ago, but we'll be expanding over to Longview just this year. So if any of you are in that area, I don't know. What questions do you have for me? I don't know if this has been helpful, I don't know if it hasn't. I'm just glad to talk through things and answer any questions for you, and just so much.
Too much.
Well, we do have a clinic, we have one clinic at Mother Francis. They're moving us into the new oncology building there, actually, the one that they're building over on the Mother side of things. At UT, we still are at UT North, up there. We do see some patients occasionally. If it's easier for people and I'm down around the hospice, sometimes I'll bring people to just do a little clinic at the hospice because it's closer to where they live, and whatever's easiest to get out of the car and move around in, we try to do for you. So, and we are hoping to have a new outpatient clinic area, but right now we're in transition. We were using office space at TMA, Tyler Internal Medicine, over there at Bergfield, but their Friday afternoon clinic space got filled up, and so they were giving it to us actually for about 2 years, which is super nice of them. But they're not we're not over there anymore. So, but you're welcome to give us a call or reach out. We also, if you have loved ones that are in a facility, we are now doing palliative care consults in nursing home facilities, the ones that have given us privileges to come in to have these conversations and talk through things for those patients. Or if you have a bed-bound patient at home, those patients really get lost in the system because by the time that they end up in the bed, it's very hard to get them to the primary care doctor, so they end up in and out of the ER because it's hard to get to a clinic to catch things earlier on. And so we do have now, we have one of my nurse practitioners is actually doing home visits for patients that are full bed bound. They can't get to their clinics too. So we're trying to expand our services, yes.
So do you have to have a referral from a
doctor to talk?
Typically, yes.
Okay.
We have to have so, and the reason is because, we can very easily be, turned into a pain clinic. And so we can't do we typically don't see people without a referral from the doctor because we wanna see your chart. We wanna see that you have a condition that is chronic. So long as you have something that is incurable, we would see you. But if someone, because we do pain management, there's not a lot of that in the world. Anyway, I'm not here to see chronic back pain, right? Unless it's in a patient that has dementia that is struggling with other things, right? So then I'm glad to help with symptoms, but it needs to be someone that has chronic disease. Yes.
How is your clinic tied to the hospice on University?
Well, so our services are tied to the University Hospice. Not that you have to be on hospice and not that you have to go to the hospice of East Texas if you ever go to hospice, by the way. But our physicians that started this group, we started a nonprofit called Texas Palliative Care. And we were the physicians of the hospice of East Texas that started this group. And so in palliative care, you don't make enough money to support yourself. And so the hospice of East Texas, because they're a nonprofit, gives us money to our nonprofit to help support us having a secretary and our doctors and our clinics and those things because of the amount of time that we do for clinics. So we are associated, but if you were to ever see us or ever make the decision for hospice and you said we want to go with Heart to Heart, I would tell you they're a great hospice and they have great employees. It's not that you have to do with one group or not. Am I biased and love the hospice of East Texas? Of course I am. I'm their medical director. So of course I'm biased. But do I think there are great hospices here locally with great nurses that do a good job that aren't us? Of course there are. Of course there are.
So the nurses over at the university that, come, like my mom's at home, are they trained by you guys?
Yes, they are. They work with our team and all of that. Yes, they work with our groups. So yeah, but, and depending on the week, like last week I was in my hospice hat and worked hospice. I did the inpatient unit. This week I'm back at the hospitals and I'm doing consults and I'm palliative care again. So it's two separate jobs technically, but it's a good question. We are affiliated, but we are independent as well.
Dr. Ferguson, I want to be respectful of your time. Thank you so much for
Go
coming.
ahead.